Hi, I'm Shashank Bhargav, and you're listening to Three Things, the Indian Express news show. Today, it has been exactly 8 months since the first case of the novel coronavirus was detected in India. Since then, the pandemic has raged on. From that first case that was detected in Kerala in January, the virus has now infected more than 60 lakh and killed over 95,000 people in the country. Some estimate that India will soon surpass the United States as the country with the most number of cases. And even as the cases rise, the government has continued to ease restrictions in an attempt to tackle the economic crisis that has been induced by the pandemic. There are a number of problems that India faces right now, from the lack of hospital beds and proper health officials, the rising cost of treatment, how much and the way we are testing for COVID-19, the extent to which we are contact tracing and doing surveillance, and how in many parts of the country the government is aggressively pushing for unscientific methods like homeopathy in an attempt to fight the virus. We have reached a point where nearly 80 to 90,000 cases are being reported every day, with sometimes up to 1,000 deaths. There are a lot of things to worry about how India is handling the pandemic, and one can't help feel frustrated. And so in this episode, we asked three COVID-19 experts about what they find most frustrating about India's handling of the pandemic. And they tell us that it's everything from what we know about the pandemic, what we are doing about it, and how we were ill-equipped to handle it in the first place. We start by talking to Dr. Gagandeep Kang, who is one of India's leading clinical scientists and virologists, and who helped develop India's first indigenous vaccine named Rotavac for the rotavirus.
I think what frustrates me most is access to data and data in a granular form so that you understand beyond the big numbers what is contributing to them.
By big numbers, she means the ones we have for the pandemic in India. That is, the number of tests that are done, the number of cases that are identified, the number of deaths, and the number of cases that have recovered.
So let's take the first and last, testing and recovered cases. So if you look at testing, what I would really like to know is, in one place, what are all the tests that have been done? I'd like to know which ones were RT-PCR, which ones were antigen, and not only would I like to know which tests were used, because even within RT-PCRs, there is a lot of variability in the performance of different tests. So I'd like to know which exact RT-PCR was done and what the results of those tests look like. I'd like to know how many antigen tests were done and what the results of those tests were. To some extent, you do get numbers from some locations in the country, but you literally have to go state by state and try to see whether these numbers are available or not.
The lack of collated data has been a big problem for experts. There is no one place where you can go to find out what is happening in the entire country. Like in this case, if you don't know how many rapid antigen tests are being done versus the RT-PCR tests, then you can't fully trust the number of cases detected. Because while the RT-PCR test is considered the gold standard for testing, with the rapid antigen test, the chances of a false negative are much higher.
Now, that is the laboratory component of testing, and that's important. But I'd also like to know why the tests were done. Were you doing this test for a traveler, somebody who had come from outside the country, or a traveler within the country? Did you do it for someone who had symptoms? Did you do it for somebody who was a contact? Was this person a healthcare worker or not? You don't need information that violates privacy in any sense. But in order to make sense of the testing data, to look at what direction the trajectories are going in, and to use this data for prediction, you need to have all of this information available. And this is just, the testing for acute disease. I'm not even getting into testing for the sero surveys and what is being done in those. Those are way more complicated.
And none of this data is readily available right now. Dr. Kang now talks about the recovery rate.
What does a recovery rate mean? When you have a mortality that we are currently told is less than 2%, then your recovery rate is 98%. So, why does the number of cases recovered in a day mean anything? And I don't understand what recovery means. Does it mean you tested negative, but we are not testing? Does it mean you were released from hospital or you were released from quarantine? I don't know the answers to that. Did you leave with no sequelae? We are hearing lots about long COVID, that people have symptoms that continue for a while. Are they included in this or not included in this? So, what constitutes the number that is classified as a daily recovery? I'm not really sure what that is, and that it is actually matched between states, because states have their own protocols for how each case is handled. So it would be really great if we could have more information on each of these categories.
And it's not just these two categories. There are similar problems about the number of deaths reported as well. Different states are reporting things differently. So when you look at the number of total deaths, there is a lot missing there. India's relatively low COVID-19 death rate has come under question, especially because India doesn't really have a great database on the cause of deaths or on postmortems. Dr. Kang says that if we had all this data, we would know where things were headed.
Let's remember that this is an epidemic where most people will recover. Even now, more than ever, we know that a lot of people are asymptomatic. The ones we worry about are the ones who are going to get really sick. And if we know as a proportion of the population, of all the cases, of all the tests, of all the disease, what is the real proportion of very sick people that we are seeing? And if we are seeing that with any degree of accuracy, it then becomes easier for us to predict what the demand on healthcare services is going to be, to ensure that the healthcare services that we provide are available to people at a time when they become sick. Do you have sufficient oxygen supply? Do you have enough nurses, enough doctors, enough beds to be able to manage this number of cases without stressing the system out? So, to ensure that there is healthcare system capacity to get the best possible outcome for people who are severely affected, having granular numbers is very, very important.
And this is true because we know that getting treated in an unstressed healthcare system makes a lot of difference. She says that in India, the problem with data is that there are many, many systems of collecting data. Some of it overlaps, some is distinct, but very few are joined up together.
So you may get data from one source, but you can't match it with similar data from another source. And you don't know until you get into the weeds what the sources of the mismatch are. And then if you take that data and move it up multiple levels of hierarchy in a data system, you become further and further away from any ability to correct that data or understand it well. So having coordinated data system is a prerequisite for being able to handle diseases. And we just don't have that.
Dr. Kang works on vaccine preventable diseases. And in that field, you have to estimate the extent to which a particular disease impacts a population, like the number of years of life a person loses because of the disease. And she says that when trying to estimate that, one often has to create a whole new data set. And that is done for almost every disease.
It should not be necessary for us to create a new data system for every disease that we have. But you look for data for tuberculosis, that's not in the same place as data for HIV, or data for malaria, or data for COVID, or data for rotavirus, or typhoid, or any other disease you care to name. IDSP, the Integrated Disease Surveillance Program, was established to be able to do all of this. But we've taken many systems out of IDSP. And I think this is time for us to rethink that if we want national surveillance, we have to stop being so disease specific. No organization or no institution should be responsible disease by disease. There really needs to be an integrated program that handles all the data for the country from multiple sources and then figures out ways to integrate this information.
This kind of information will also be useful if and when India develops a vaccine for COVID-19. She says that at that time, we would need to come up with a vaccine strategy to decide where vaccine programs can be set up first and how much supply we will require. But without proper data, it would be hard to do that. Dear listeners, sorry for this interruption, but before we move on to the rest of the show, I just wanted your quick attention. One of the big reasons people say they like this show is because it helps them understand the news better. It provides them with the context they need to see the bigger picture. And there is perhaps no other place that does that better than Indian Express's Explained section. We on Three Things refer to the section regularly, and it helps us make this show. If you're a regular reader of Indian Express, you know how useful the Explained section can be, especially when you're looking for in-depth analysis by the right experts. You can log on to indianexpress.com/explained and access the coverage 24/7. Explained by Indian Express, where news that matters is explained by experts who know the subject. Now, back to the show. So that was one expert's frustration about the lack of granular and integrated data to understand where the pandemic is headed. The next person we speak to is Dr. J Prakash Mulhil, who is one of India's top epidemiologists and the chairman of the Scientific Advisory Committee of the National Institute of Epidemiology. And he says that a lot of things have frustrated him. One of them being that because this virus is new, there were many things we didn't know at first. And on top of that, there was a lot of misinformation about it.
Now, as the disease started spreading, it being eminently apparent that we cannot control the transmission of the virus. It is extremely transmissive. The only way we could have controlled it, like what some developed countries did, everybody sit at home for several weeks, like New Zealand did. Now in India, that was just impossible because people had to live, had to eat, feed the children, and they had to go to work. So this is kind of an impossible situation.
And because people who relied on daily wages couldn't afford to just sit at home, he says that the lockdown didn't really work. For example, thousands of migrants were forced to travel back to their villages, many of them by foot, at a time when the government was asking everyone not to get out of their homes.
Once you recognize that this is not going to work out, we should have reversed it early itself. And we continued to pursue what is called containment strategy. As a result, so many lost their livelihood. It was hardship all the way because the focus had to be immediately providing healthcare for people who needed healthcare with COVID. And that would have transformed the whole scenario. There would have been casualties, just like we had now. But we would have had our work going on, industry going on, economics going on.
He says that once there is community transmission, there is no point in trying to contain the disease. He feels that India should have realized that early on. The government, though, despite having such high cases, has never acknowledged that there is community transmission in the country. and has faced criticism for it. Dr. Mulhil says that the extent to which the disease has spread can also be seen by the recent serological or serosurveys, which are essentially done to find out how many people have already been infected by a disease.
Once we found that with the serosurveys, the huge amount of cases around which we have not seen, because a large number of transmission was subclinical or mildly clinical. So the numbers we put on the TV as recorded cases was no match for the real number. Even then, we doggedly pursued this containment strategy. Now, it has cost people a lot, individuals, families, and that is the tragedy of our pursuit.
He says that there shouldn't have been a delay in relaxing restrictions which affect people disproportionately.
What are we afraid of? Opening fully. You understand? People will fall sick. They are falling sick anyway. And that is not the question. Young people have a low mortality. It is recognized. Children don't have any grave consequences. That should be recognized. I know we are taking a downward trend in economy, but the problem with that downward trend, it doesn't affect many of the people who are well settled. It will affect a large chunk of people who are used to poverty. And that is the tragedy of it. The children who need nutrition, education, future, we're all blocking it. And there should not be any pride involved when you do such things.
Dr. Mulhil says that instead of focusing on restrictions, we should have focused more on preparing for adequate healthcare for those who were going to be severely affected. But that, he says, wasn't done. And the other thing he says that we aren't focusing on is the immunity that COVID-19 survivors are developing.
At the moment, we are almost approaching a level of herd immunity. But for every bit of transmission accompanied by death, which we could not avoid, what to do? It is that kind of virus, and preparedness for meeting certain eventualities absolutely nil. But one thing that stood out very clearly, the disease was inducing excellent immune response from the people. Now we are chasing the vaccine, hoping it would come. But the fact remained, we are not able to recognize the fact people who have already had the disease are immune-wise competent to defend themselves against any future disease due to COVID. And that is extremely frustrating.
The idea of herd immunity is that if enough people in a population develop immunity towards a disease, then they reduce the chances of others getting infected. And he feels that that is what will happen with India, considering so many Indians have already been infected and are immune. He is also confident that the vaccine, when developed, will by and large be effective. Though not everyone shares his enthusiasm for the vaccine or the immunity that people develop from the disease. Many other experts have pointed out that the vaccine for COVID-19 may never be developed, and that we aren't sure the extent to which people are developing immunity and how long it actually lasts, especially considering there have now been a handful of cases of reinfection around the world. But talking about the decision of the lockdown and the way it was implemented, he says that the government should have acknowledged that it was a mistake and acted on it accordingly.
And there is no harm in changing course, looking at things afresh. In science, failure is common, but recognition of the failure gives you a scientific temper. When you refuse to recognize mistakes, then I don't know how to describe the person or the persons for that matter. Tomorrow, if there is going to be a proof that herd immunity doesn't work out for some reason, I'll be happy to admit, yes, I made a mistake. And that should be the approach I seek in people.
He says that this is the attitude that should be adopted by everyone involved in handling of the pandemic.
This is not anybody's personal matter. It's a national priority, a national disaster. We need to work together. There are no parties here. No gender, no language. We are all together in it. Only science should guide us. And when that doesn't happen, it's highly frustrating.
So, to sum up Dr. Mulhil's frustrations, it's the lockdown, the fact that we are still pursuing the containment strategy, not focusing enough on healthcare facilities, and that we are not acknowledging that survivors are building sufficient immunity. And now, in the end, we speak to Dr. Giridhar Babu, a leading epidemiologist and the head of Life Course Epidemiology at the Public Health Foundation of India. When we ask him what he finds frustrating, he says that it's India's short term approach to a long standing problem.
So, in my sense, what I was hoping was that through the COVID-19 pandemic situation, there will be sort of a wake up call for improving our long standing problems in ensuring that the public health system gets strengthened. And that is my greatest disappointment because whatever we are doing currently seems to be mostly reactive in nature, but very little is being done except for some of the human resources. Otherwise, I don't see in the long run how are we ensuring that the public health system is getting strengthened. So that's my biggest concern.
To explain this further, he talks about people who have comorbidities, that is, those who have more than one medical condition at the same time. These are the people that are more likely to have a complicated condition when they develop COVID-19 and the ones that are more likely to die from it.
Let's look at just hypertension. 1 in 3 adults have hypertension, which is high blood pressure, but nearly 50% of these people are not diagnosed. On the other hand, we have insurance for somebody getting a heart attack or a stroke once they're hypertensive and continue with that state for 10 or 15 years. So, which means there is incentive for curative services, but there is no system to prevent those complications in the first place. Same thing with the type 2 diabetes mellitus. In one of our study, which is led by Professor GVS Murthy in 9 states, we found nearly 50% of the people are blind by the time they come to know that they have diabetes.
He says that unless we are going to work towards preventing and controlling non-communicable diseases like these, we are going to continue to have a tough time when a crisis like this occurs. This is what public health focuses on.
Public health is about preventing diseases and promoting the health. And when we say health, it's complete state of well-being, physical, social, and mental, not just the absence of disease, which means we have to go outside the medical paradigm to ensure that our people are healthy. And that will not happen until we address there is good food, nutrition is ensured, good drinking water, there are walk lanes for people to walk, there's enough clean air. All these things are the determinants of health. These are the most important from preventing the diseases point of view.
And these are things that require a long-term strategy and work all year long. But the system, Dr. Babu says, is geared towards curing a disease and not preventing it. But even if we are to consider measures being taken during the fight against COVID-19, they vary from one part of the country to another. He gives the example of how we are doing disease surveillance in the country.
Now we found that some states have higher burden, some states don't. And suddenly people say, okay, only these states are the problems. But the real issue is different. The states which are reportedly having more cases is so because they have better surveillance system. The states which do not have that kind of a robust surveillance system will always report late. Even within a state, there are regions which have better and poor surveillance. So we need to ensure that the health security index, what we call, which includes surveillance, early warning signals, is strengthened everywhere. And for example, Centers for Disease Control in US gets millions of dollars for just surveillance and research which is aimed at preventing diseases. And if you look at the budget for National Center for Disease Control, yeah, it's abysmal. to compare to what the country of this size should have.
India approximately spends 1% of its GDP on public health. This is one of the lowest in the world.
So instead of waiting for people to become sick and then take care of them through insurance schemes, which is good to help at least those who are needy because out of pocket expenditure is really high. This is not sustainable in the long run. We need to prevent these illnesses in the first place. So through this pandemic, we should also be prepared to fight any pandemic in future, not just from the health point of view, also from the security point of view.
We asked Dr. Babu what would have happened if India did have a better public health system like the one he talks about.
You can always compare the outcomes of states which have better system versus states which do not have, and countries which have such a strong public health system against those who don't have. Let me bring in the example of Germany to begin with, and how they handled so well when the entire Europe was crumbling. They could really do well. If you look at Australia, New Zealand, their public health system is so strong that they know exactly where the case is coming from, and then they can afford to ensure that their area is geographically isolated. But in a country like India, looking at Kerala, how they tracked from the first case till now shows that how robust health system they have, and they also have involved many volunteers, which is what public health is all about. It can't be only by health department. But if a strong system was in place, we should have been able to minimize the impact, especially the number of deaths we should be able to reduce, because the comorbidity would have been treated well. They would not be at higher risk of death. Since India has high proportion of young people, our death rates would have been further lower. So there are umpteen advantages. I mean, this is just one to mention.
He says that India's problem of not prioritizing public health is not unique, and that most of the low and middle income countries have mostly spent on curing diseases. And the only preventive service they have spent on is immunization through vaccines.
And if you look at how countries decide on spending money, immunization money gets spent by the country because there is immense advocacy by World Health Organization and many others. And in the private sector, reimbursement of the medical expenses occurs because there is a legacy, right? The private sector is very strong. They know how to get their demands met. So therefore, even now, from one budget to another budget, the insurance and the reimbursement cost to the private sector is only increasing. So this is a direction which I'm really scared of. I'll just give you an example. The United States spends nearly 17% of their GDP on health. By that, we should assume the US will have the most healthy people, but that's not true. Most of this money goes to the insurers or the diagnostics or the pharma companies. Very little goes to the hospitals or the doctors.
And this is the direction he fears India is heading towards.
So we might end up spending a lot of money on the curative services, but as long as the feeder pipe of illness is not addressed, if there is no preventive services, if there is no determinants of health taken care in terms of even ensuring food security or water security or environmental health, if these are not addressed, we are going to have sicker people and have to spend more money towards the private sector. I'm not blaming here. Private sector is absolutely important aspects of healthcare services. But no private sector can manage the kind of numbers that we are speaking when they are, if you just look at how we are managing with COVID-19, private sector is very helpful, but it's only helpful when the government system functions fine. They can't function on their own. So preventive services is in the realm of the public health sector, and that's what needs to be strengthened now.
And he says that what we need is a public health cadre, one that has influence over other departments in the government.
So just to give an example, at the national level, it should be headed none other than by probably highest level, like cabinet secretary or the prime minister himself, who will then have to give directions to different departments For example, road transport for road safety, Department of Agriculture for food security. All these are determinants of health. Unless we look from that broad determinants of health point of view, we are not going to reduce the illness either in the short or long term.
You were listening to Three Things by the Indian Express. Today's show was written and produced by me, Shashank Bhargav, and as always was edited and mixed by our producer, Joshua Thomas. Before we go, here's another reminder to check out Indian Express's Explain section. You can log on to indianexpress.com/explain and find in-depth analysis by the right experts. It has everything you need to know to understand the news better and see the bigger picture. If you like this show, then you can subscribe to us wherever you get your podcasts. You can also recommend the show to someone you think will like it, share it with a friend or someone in your family. It's the best way for people to get to know about us. You can also tweet us at Express Audio and write to us at podcast@indianexpress.com.